The two main goals in diagnosing venous thrombosis are to determine 1. The presence or absence of intraluminal thrombus, and 2. The relative risk of embolization of the contained thrombus. Venous imaging is uniquely suited to both of these tasks. This portion of the tape explains how to differentiate thrombus-free veins from veins containing thrombus. In addition, it emphasizes the importance of observing such things as degree of attachment to the vein wall, echogenicity, and texture of the thrombus. Attention to these characteristics can help in assessing the potential risk of embolization of a given thrombus. First, we will discuss the on-screen appearance of normal veins, referring to the vessels as they are visualized from a transverse plane. The deep veins are located alongside a corresponding artery. This artery can be used as a landmark to find the vein. The artery is a thicker structure and is visibly pulsatile. In contrast, the vein has thin walls that are held open only by the pressure of the blood within it, i.e., the transmural pressure. This is an important point because the size and appearance of the vein varies greatly depending on the pressure within the venous system. Many factors may affect the caliber of the vein during ultrasonographic examination, the most common being patient positioning. The extremity being examined must be below the level of the heart in order to fill the vein with blood well enough to visualize it as a round, fluid-filled structure. Elevating the extremity above the heart causes blood to empty from the venous system, permitting the vessel to collapse. This may make the vein difficult or impossible to identify during the ultrasonographic examination. Positioning the extremity at the level of the heart usually allows visualization of the vein as a partially filled, elliptical-shaped structure, which is less than optimal for clear ultrasonographic imaging. Proximal compression is another factor that affects the size of the vein being imaged. If a section of vein above the level of the vein being imaged is compressed or kinked, blood flow stagnates and the size of the vein increases. Dramatic changes in vessel size also occur with the Valsalva maneuver, which causes the vein to increase to several times its normal size. The most important dynamic feature of a normal vein is, however, the fact that it will completely collapse in response to light probe pressure. This is the key to venous imaging. When the vein walls completely collapse in response to light probe pressure, the vein is unequivocally thrombus-free at that location. Thrombus can be said to be present within a vein when solid echogenic material is visualized within its lumen, and when the presence of the echogenic material is confirmed by the failure of the vein to compress fully in response to probe pressure. Additional techniques for identifying thrombus that is not immediately visualized will be discussed later. Once thrombus has been identified, the examiner should evaluate and characterize it. Some observable characteristics of the thrombus can provide clues as to its age. They include those characteristics usually associated with acute thrombosis. 1. Lightly echogenic thrombus. 2. Poorly attached thrombus. 3. Spongy textured thrombus. 4. Dilated vein when totally obstructed. And 5. Smooth borders. The characteristics of chronic thrombosis are 1. Brightly echogenic thrombus. 2. Well-attached thrombus. 3. Rigid textured thrombus. 4. Contracted vein when completely obstructed. 5. Irregular borders. And 6. Larger collateral veins. Each of these characteristics will be discussed individually. As a general rule, the newer the thrombus, the more lightly echogenic it appears on the screen. Some clots are nearly invisible when they first form and would be missed on ultrasonographic examination if not for the fact that the invisible thrombus prevents the vein from completely collapsing. As time passes, the thrombus becomes more dense and the echoes can be more readily observed. When new thrombus forms, it attaches to the vein wall. As it begins to propagate, however, it can form a long, snake-like tail that extends into the lumen of the vein without any other point of attachment. This poorly attached type of thrombus is displayed quite dramatically by ultrasonographic imaging. it is usually associated with new growing thrombus. As the thrombus ages, it will eventually either lyse or attach more firmly to the vein wall. Newly formed thrombus in the venous system resembles a gelatinous substance. Under ultrasonographic examination, it has a lightly echogenic appearance and deforms slightly when pressure is exerted over the vessel. The longer the thrombus is present within the vein, the more tightly contracted and therefore rigid it becomes. As a newly formed thrombus grows, the vein enlarges to accommodate the blood flowing around the partial obstruction. The vein can do this quite successfully until it reaches its maximum caliber, at which time the thrombus completely fills the dilated vessel. When the vein is imaged in the transverse axis, it can be several times larger than an ordinary patent vessel. Newer clot tends to have a smooth border as opposed to an irregular one, although this observation is one of the least reliable indicators of the age of a given thrombus. As it ages, thrombus becomes more brightly echogenic. This makes thrombus easier to see for a while, but as the aging process continues, the thrombus becomes so brightly echogenic that it begins to blend in with the surrounding tissue. This is one of the reasons why patients with very old disease have vessels that seem to disappear over time. As it ages, even a loose thrombus will attach to the vein wall. How securely a thrombus is attached can therefore be another indicator of the age of the thrombus. As clot ages, it becomes more dense and contracted. Therefore, it becomes very solid. Extremely old thrombus may actually become so dense that it creates acoustic shadowing. In contrast to the gelatin-like consistency of newly formed thrombus, older thrombus is firm and rigid. If a vein is completely filled with thrombus, and if that thrombus is well attached to the vein wall, the thrombus will take the vein wall with it as the clot contracts. This continues with time until the vein is small and contracted. This process, along with the brightly echogenic appearance of the remaining thrombus, further contributes to the disappearance of the vein during the chronic phase of venous thrombosis. As thrombus ages, its borders tend to become more irregular, which can cause older thrombus to resemble plaque formation that might be seen in the arterial system. This is especially true of extremely old thrombus that is partly recanalized. When a major vein is totally obstructed, nearby vessels enlarge to move blood around the obstruction. If the obstruction of the vein is permanent, these collateral veins continue to enlarge until they are noticeably larger than normal. Although collateralization actually begins as soon as a vein is obstructed, extremely enlarged collateral veins are not seen clinically until the subacute to chronic phase of the disease. These distinguishing characteristics are not absolute. They are, however, useful tools in estimating the age of a thrombus and the risk of its embolization. Since clot dissolution, with lytic therapy or spontaneous lysis by the body's own thrombolytic system, may occur in some cases of venous thrombosis instead of simple stabilization and contraction, all clots may not follow a predictable pattern of aging. Nevertheless, the true chronological age of a clot is clinically less important than its stability. To safely manage the patient with venous thrombosis, the physician must know whether or not a thrombus is stable. Therefore, the true value of the venous imaging procedure is its ability to differentiate clots that are poorly attached and spongy in texture from those that are well attached and rigid in texture.